thinking as I was listening to you about what is it that we measure if we're going to do more of this work, and the measurement of something from the patient's or the person's perspective. So patient-reported outcomes, basically. And Michelle talked about some feeling supported. I feel supported now. I wonder, all of you and everyone here, what could we be measuring, and are we ready for this research area to be looking at what the person says? What do we need in that, for that issue? I've recently, let me go on just for a second. I've been working on a project with a large group of people, and the National Institute on Aging has a big focus on patient-reported outcomes. So in meetings about that, and in meetings with drug companies and researchers, you raise this issue of what does the patient think, what is the patient's response? And you get a sort of glazed over, you know, the eyes glazed over. How could they possibly report anything? They have dementia. They don't know that they have dementia. And yet what all of you are talking about is early stage people where maybe not, and where the intervention is really for the person. Are we going to keep relying on that the family member said so? Or should, so that's what I'm thinking about. What do we need to do there?
Well, I think most of us in the room would agree that people with early stage dementia can tell us what they're feeling. And I know there's a bunch of research that many of us in the room have done that shows that people with early to moderate level dementia, let alone people who aren't demented, can report back on, but they can. And I think there's lots of questions we can ask them. We've asked them about their values for care. We've asked them what do they prefer. We've asked the caregiver what they think they prefer, and the caregiver's kind of wrong. Not always perfectly accurate. Again, all of us know this. There's lots they can say. They can talk about their health. They can talk about so many things. They can be involved in interventions. They can do all kinds of things. So I think it's endless what they can do. And I think every time any of us present about this, there's always a question in the room. Why are you asking the person with dementia how they feel? They can't possibly answer your questions, and that's just not true. So it's constant education that they can do this. And we've been doing this research since the 90s. They can. And again, caregivers don't know what their relatives want all the time. They have a general idea, but they don't know exactly what they want. I think you have similar research that says that they can be asked questions. What works best, we found, is that they're asked in person. Sometimes a self-report doesn't work so well when they are filling out a questionnaire. But if they're asked in person, they do very well. High reliability, high validity, all the big research words are there. But we shouldn't be afraid to ask them what they want.
I think it also may depend on where we're trying to translate the interventions. If we're trying to place them in healthcare settings or community settings, those folks tend to respond differently to how their constituents are being treated by another provider. I know in a healthcare situation, a healthcare setting where we have been trying to implement evidence-based interventions, our providers, we want our providers to see us as another service line. We're not a research project. We're yet another service being offered by an integrated healthcare system. So they don't want their patients coming back and saying, hey, these people gave me a baseline interview. They want to hear us say, we did some type of initial assessment or some initial paperwork, first visit assessment, that kind of more intake language in which they hear us collecting information that will help us in our treatment process. So depending on where you are, I think you have to understand what the culture is and how they will respond to what you're asking of the people they're sending to you. And the feedback, the constant feedback to the providers of this is who we're working with, this is what we're asking them, this is what that we're finding, and here are our results, are key to translating in healthcare settings.
I just want to add to that I think the emphasis on early on is important. In the downward trajectory of the disease, what we found is when we interview our care receivers, we're not having the numbers on care receivers as time passes. So the emphasis on early on is important. I have a question, but
As you all move forward, one of the things that the language that we speak where I am at CMS is how do you what's the business case for doing what you do, and that means how does what you're doing providing better care for patients, improving health of populations, or and it could be your community, it could be defined in many different ways, and then how is it going to reduce costs of Medicare and Medicaid? So because a lot of people do run through and just so think about that and as you move forward in your work.
I guess I'd like to respond to that briefly, and it kind of follows up on the question of assessment. You know, in our program, we're not just working with early stage folks. We are working with folks that have the whole spectrum of cognitive impairment. And I think the issue of self-report in terms of assessing quality of life, you know, my colleague Dr. Logston has this quality of life measure that she's developed and that's pretty widely used and has clearly shown that folks down to a mini-mental of 9 or 10 can very reliably use it. And again, the responses don't necessarily agree with the caregivers. But I believe that even people with more advanced dementia, they certainly do tell us what they think and feel and like. They tell us in ways that maybe can't be measured with some of our self-report measures, but they are clear to us, for example, with an exercise program, if they want to do the exercises that you're asking them to do or not. And so I think part of it is coming up with objective measures that we think are part of a good business model. So for example, if by having someone on an exercise program, you reduce their level of daytime agitation and restlessness, and so the caregiver is able to keep them at home longer, that has clear cost impact benefits, and it also is something objectively that can be measured. If you're able to reduce other measures of physical frailty, we're in the process now, one of my colleagues in the office is working with Dr. Terry about getting funding to look at some novel ways of measuring things like gait and physical function as a result of being in an exercise program. Assessments that can be done easily in the home for relatively little expense by someone who's trained to use pretty simple software to do it. Again, it would be an objective measure that would show the cost benefit of the program. The more difficult thing, I think, is coming up with a way to evaluate these more subtle, the person with dementia tells us what they like, what they want, and we, the caregiver, and we, the clinician working, can see that. But how do we put that in some sort of a measurable way that can be compared across individuals? And, you know, we've been grappling with that since goal attainment scaling came out. We just haven't figured out how really, but I think that's part of what needs to come, as well as this, you know, protocol for training is a protocol for assessment that incorporates this, what the person with dementia, even with advanced dementia, they tell us in their own way, and how do we evaluate that?
I think that's really important, and not just looking at quantitative, but being very open to how we ask the right question. I'm not sure we know how to ask the right question yet to obtain that information, and so really thinking creatively about how you ask the right question. One of the unexpected and actually one of the most memorable pieces of outcome data we had was when I was talking to a couple about their relationship to our program and the impact, and the wife said, you know, he doesn't know if it's Monday, Tuesday, Wednesday, Thursday, or Friday, but the morning that he comes to your program, he wakes up and says, this is my day to go to Minds in Motion. And I thought, wow, that was meaningful. And would I have known the right question to elicit that? I'm not sure. But so I think being open to and trying different questions and really not just looking at quantitative outcomes, but how do we ask the right questions to also capture meaningful outcomes?
I think it's hard to translate without just oodles and oodles of money. What somebody's saying that they have a support network now that they can rely upon equals in terms of cost savings longitudinally to Medicare. I don't know. I could use some help thinking through that. So.
Just a couple of thoughts, sort of to piggyback on what Lisa and Susan were saying, is looking at other measures like observational ones. There are some out there, and maybe looking at ways to expand upon that. And then wanted just to make a comment about any time that you're interviewing or you're doing a one-to-one with somebody with dementia, there is more cost involved. So looking at just the costs of doing studies like this, but then the value and the takeaway of that. And then I just wanted to ask one more thing, if I'm allowed, since I have the mic. Susan, wanted just to know, and really for all of you, in regards to the exercise piece, has there been thought, or is there study around the impact on sleep and sleep disturbance? It comes to mind, and sort of the regulation of circadian rhythms and all the stuff that we know about sleep.
Well, there's a large body of literature on the impact of exercise on sleep. Our group has also done some of that research where we've looked at sleep and Alzheimer's disease and looked at the impact of walking versus increased light exposure versus some combination of these interventions. And what we've seen is that indeed you can improve sleep about as well as a typical drug does. You can improve it about 45, 50 minutes a night by putting someone on a systematic walking program anyway. That's what our research has shown. The challenges with that in a translational study such as RDAD is not prescriptive with regards to time of when the walking or exercise is going to be delivered. There's not any assessment being done to look at circadian patterns in the individual who's exercising. So if you were going to target sleep per se, you would have to kind of take some of these additional assessment components in and kind of target your delivery. That said, it's pretty safe to say that if you've got an individual who is more physically active during the day, then they're less likely to be inactive and sleeping during the day, which would be expected to have a positive impact, at least for some individuals, on their sleep at night. So I think there's potential there. There is also, though, I have to say a caveat, since this is my line of research, that there's a question of whether the amount of sleep improvement that you get from something like an exercise program in a person with Alzheimer's disease is clinically meaningful to the caregiver and worth the trouble of doing the exercise just for that purpose. And what our research suggests is a person has to be sleeping maybe an hour or more better a night for the caregiver really to think this has made a difference, that it's worth it. And so I think exercise has potential to have an impact on sleep, and in some individuals, a big impact in sleep. But I think exercise, to have broad application as a translation component with Alzheimer's care, needs to have a bigger agenda than that, because not everybody has sleep problems, and the sleep problems have to improve a whole lot for it to matter to the caregivers and to the care recipients themselves. And so I think we would believe in exercise for all the other benefits that it has to do, the improvement in mood and the pleasant events experience that it can be for the caregiver and the care recipient, and decreasing risk for falls and some of the other frailty things that exercise has to be part of a big package, I think.